Hello and good afternoon from Bielefeld. I am Carl Thies, and today I'll be talking about a very special form of cardiac arrest, the traumatic cardiac arrest, or short TCA. I have no conflicts of interest to declare. The outcome of TCA is poor, and resuscitation of these patients is still by many regarded as a futile exercise and a waste of precious resources. Nevertheless, a change of mindset has happened over the past decade, mainly driven by the experience of the armed conflicts and the developments in trauma resuscitation they've brought about in Europe. Getting advanced trauma care early to the patient and minimizing the time to definitive treatment is the key to success in critically injured patients. The medical response teams basically took the principle of damage control resuscitation onto the battlefield, trying to achieve hemorrhage control as early as possible and starting resuscitation with blood products. This approach, followed by immediate damage control surgery after hospital arrival, had an enormous effect on survival. This graph illustrates the deterioration of a bleeding casualty over the course of time. The blue line shows the stage level of care for major trauma patients. Level 1 is basic field medical care or first aid. Level 2 is advanced pre-hospital care, and Level 3 trauma center care. This often didn't match up with the soldiers dying en route with potentially survivable injuries. Moving care to the front line was the logical consequence. The military colleagues have coined the term forward resuscitation for this approach. This has made a huge difference in survival, with the mortality rates of battlefield injuries dropping from 17 to 8%. Here, the care bundle makes the difference, but it is not clear which component of the care bundle has more or less impact. This graph shows the probability of survival against the corresponding injury severity score. It demonstrates that the chain of survival has improved year by year and that patients with ISS between 30 and 60 benefit most from advanced trauma care. An interesting finding is the convergence of the curve on either side of the spectrum. As I said before, it is the advanced care bundle that makes the difference, but it's extremely difficult to single out certain measures that are particularly effective. The lessons learned from the military can be broken down into 3 key components. It's all about time management, having a plan, and being capable to put this plan into practice. This in turn requires a high level of skills, an excellent team, and intensive training. And training is the link to the traumatic cardiac arrest algorithm, which we have created to train teams. If you look at the top box, you'll see that this algorithm is also for patients that are not in arrest yet, but about to die on you if you don't take any action. So in fact, this algorithm can be used for all trauma patients with affected vital functions. The focus of treatment in TCA is on the reversible causes. They need to be addressed in a simultaneous manner according to their priority. And the priority is established during the brief initial assessment, the so-called 5-second round. The first decision that has to be made is whether a non-traumatic cardiac arrest is more likely than a traumatic cardiac arrest. If this is the case, it would trigger the standard ALS algorithm. If this is not the case, we put priority on tackling the usual suspects: hypovolemia, hypoxia, tension pneumothorax, and cardiac tamponade. The so-called reversible causes of traumatic cardiac arrest, which are to be addressed in a prioritized simultaneous fashion. We prioritize according to the CABC approach, but the first C stands for catastrophic hemorrhage. We recommend to address massive external hemorrhage with simple measures as external compression, hemostatic gauze, and tourniquets. Re-establishing oxygenation has the highest priority in asphyctic patients and patients with brain impact apnea. This can be achieved with simple measures as an oropharyngeal or a supraglottic airway. If we suspect a tension pneumothorax as a cause of a TCA, we recommend open thoracostomies. Chest tubes are not necessary in the first place. The patient needs pleural decompression, and as long as the patient is under controlled ventilation, a chest tube is not required and can be placed once the situation is under control. Needle decompression is an alternative if the practitioner is not trained in finger thoracostomy. However, in traumatic pneumothorax, there always is blood in the chest, and narrow needles get obstructed by blood clots easily. This may cause retensioning. Standard IV needles should not be used in adults. They are frequently too short to reach this pleural space. For relieving a traumatic cardiac tamponade or controlling massive subdiaphragmatic hemorrhage, a resuscitative thoracotomy should be considered. A traumatic cardiac tamponade is very different from a pericardial effusion that we see in internal medicine. A needle pericardiocentesis to relieve the tamponade is probably not helpful because the fresh blood clots immediately, making needle aspiration in the majority of cases impossible. If the patient is in a critical condition, an emergency thoracotomy can be life-saving. Ideally, this should be carried out in an operating theatre. If this is not achievable, the procedure may be carried out in the emergency department or even in the pre-hospital environment. In case of an uncontrollable subdiaphragmatic hemorrhage, cross-clamping of the descending aorta could be applied as a temporary measure to achieve proximal control. This might prevent exsanguination and buy some time to move the patient to the operating theatre. REBOA, that means resuscitative endovascular balloon occlusion of the aorta, is an alternative technique to achieve temporary control. Both techniques are non-inferior to each other. Both techniques are highly invasive and should only be performed if there is sufficient expertise within the team to carry out the procedure safe and professionally, if the right equipment is available, if the patient is within the right environment, and if the vital function loss is no longer than 15 minutes. We recommend the use of a pelvic splint if a pelvic fracture is suspected, and recommend the early transfusion of blood products as a cornerstone of treatment in exsanguinating patients. If return of circulation can be achieved with these measures, in the pre-hospital field, patients should be taken to the nearest suitable hospital without delay. In hospital, these patients should receive further damage control measures or sometimes even definitive care. If all reversible causes are addressed and there is no risk, termination of efforts is a reasonable option. Last not least, here comes one of the key questions. What is the role of chest compressions in this algorithm? 50% of the patients that die from reversible and potentially preventable causes succumb to exsanguination. Cardiac arrest in these patients does not occur all of a sudden and is preceded by significant changes in physiology. Venous return is critically low, depending on the pressure gradient between the right atrium and the extrathoracic blood vessels. Chest compressions and controlled ventilation increase intrathoracic pressure and further decrease venous return. This means if the patient still has any residual circulation, chest compression will finish the rest circulation off. The same is true for cardiac tamponade and tangent pneumothorax. The only form of traumatic cardiac arrest that may benefit from chest compressions is asphyxia. So the bottom line is, treatment of reversible causes beats chest compression, because if the reversible causes are not tackled, chest compressions are most likely counterproductive. Trauma care is chain care. It is very much like the new mantra of the European Resuscitation Council. It takes a system to save lives. And the same is true for the severely injured. From our colleagues in the military, we have learned what a difference care bundles make. These care bundles are complex and involve all chain partners. They need a common understanding of the process and the roles and responsibilities within the chain. So is it worthwhile to prepare for treatment of traumatic cardiac arrest? It is, because getting your processes right, getting your timings right, and getting your institutional spirit right, and prepare for the worst, training for the worst, is not only good for the TCA patients, but even more for all the other trauma victims that keep on arriving day in, day out. Thanks for your attention.
Thank you, Carl, for this excellent summary of the management of traumatic cardiac arrest. I think it was very hard to summarize everything in only 15 minutes, but the presentation was really clear and excellent. Let's see if I can see there is a question coming from the audience, from Tahani. He asks, thoracotomy is performed in pre-hospital condition, and what about the systematic thoracostomy in these patients?
Yes, the pre-hospital thoracotomy is an option indeed. It is introduced into pre-hospital service more and more in Europe. In the United Kingdom is I would say, for the helicopter emergency service already a standard procedure. And in the Dutch helicopter emergency service is a standard procedure, and we have seen we've seen a survival rate of 10 to 20%. It is a very invasive procedure. If you do it, you need to get your chain right on beforehand. Don't start doing these things without having implemented a process. That means a process with the ambulance service, a process with the receiving hospitals, and make sure that everybody knows and consenting what you're doing. Don't do this on your own. You probably will be losing your job. That's what happens, because people are shocked if you do that. And there is a lot of impact, of course, for bystanders, for police officers that help. I had police officers that held the chest open. That was this is quite an impact, and people need to be prepared. People need to be debrief. If you start such a procedure, reckon at least 3 hours debrief for the whole team afterwards and for all the bystanders. The systematic thoracostomy is always the first step before you start a thoracotomy, because that's part of the procedure of the algorithm. First of all, you stick a finger in the fourth intercostal space on the right and left side in the midclavicular line, because that's your thoracostomy. And if you don't get ROS, you open up. But the indication must be clear. The indication at the moment is if you suspect a tamponade, that's one indication. So usually that would be a knife injury, which is was going into the direction of the heart, or if you want to cross-clamp the aorta. Those are the two indications, in fact. Cross-clamping of the aorta is not very difficult. You need to do, if you a left lateral thoracotomy, and if you slip your hands underneath the lung, and you come to the spine, and the first vessel that you feel is the aorta. You can do it by hand as well, and that would be indicated in patients that obviously are dying on you, and you can't stabilize them. This is true for the in-hospital situation, you're in your shock room environment, and even for the pre-hospital situation. But starting all these invasive procedures, I would strongly suggest that you make sure, even if you're under pre-hospital fit, that you've got blood products as well. I think doing invasive procedures without having the backup of blood products is probably not very sensible. Okay, that was a very extensive answer. I think we have already used up all the time that we have for the discussion, I'm afraid.
Oh, thank you very much. Let's see if I cannot see other questions. Well, I have a question, actually two questions. One is because, as you said, it is important to have a great expertise if you want to go for resuscitative thoracotomy or other interventional maneuvers. So how easy or maybe how difficult it is to create a strong expertise on that, and what would be the role of simulation or in the training process? Do you have some suggestion to build up expertise?
You got to first. You got to have a three-step approach. First of all, is get consent you're doing this. That's the first step. So the evidence is there. Talk to your chain partners. We have to do that for selected patient groups. And I mean, not all emergency services have to do that, but I think the city emergency services in big cities that see a lot of stab wounds, they should be doing this. It's probably not necessary if you're in a small town because you can't maintain your skills. It's very difficult. That would be the first step. Get agreement of the whole care chain. We're doing this from now on. That's the first step. And then you start training. Simulation would be the first step. And simulation is more about decision making than actually about, because I'm not very good simulators on training this in real life. So that is about decision making. And decision making is crucial as well, because you have to make this decision within seconds. Don't waste any time. If you start wasting time, if you spend half an hour on scene, that's too long. That doesn't work. So you have to basically you enter the environment. You're probably briefed by your by ambulance control that there is someone in peri-arrest who had a stab wound, and you've got your mental model ready with your paramedic. You get in, and within 10 seconds you take the decision to do it. And if you do that, it takes about 1 minute till you are till you've got the pericardium open. And that's how do you train this? Go to your anatomy department. That's the only way to learn it, and do it 10, 15 times before you start this in real life.